Don't stop. Don't stop. Don't stop. Don't stop. Don't stop. Don't stop. Don't stop.
Trachea, esophagus and thoracic duct. Introduction. Trachea or windpipe is the patent tube for passage of air to and from the lungs. In contrast, esophagus lying behind the trachea opens only while drinking or eating. Thoracic duct brings the lymph from major part of the body to the root of the neck. Trachea. Trachea, Latin air vessels, is a wide tube lying more or less in the midline in the part of the neck and in the superior mediasuinum.it's upper end is contonous with the lower end of the larynx. The trachea in the neck is covered by the isthmus of the thyroid gland and acts as a shield for tachea. At its lower ends the trachea end by dividing into right and lifet principal bronchi. The trachea is 10 to 15 centimeters in length. Its external diameter measures about 2 centimeters in males and about 1.5 centimeters in females. The lumen is smaller in the living than in the cadaver. It is about 3 millimeters at 1 year of age. During childhood it corresponds to the age in years, with a maximum of about 12 millimeters in adults, i.e. it increases 1 millimeter per year up to 12 years. The upper end of the trachea lies at the lower border of the cricoid cartilage, opposite the sixth cervical vertebra. In the cadaver its bifurcated lower end lies at the lower border of the fourth thoracic vertebra, corresponding in front to the sternal angle. However, in living subjects, in the erect posture, the bifurcation lies at the lower border of the sixth thoracic vertebra and descends still further during inspiration. Over most of its length the trachea lies in the median plane, but near the lower end it deviates slightly to the right. As it runs downwards, the trachea passes slightly backwards following the curvature of the spine relations of the thoracic port anteriorly, 1 manubrium sterni. 2 sternohyoid muscle. 3 remains of thymus. 4 left brachiocephalic and inferior thyroid veins. 5 aortea arch, brachiocephalic, and left common carotid arteries. 6 deep cardiac plexus. 7 some lymph nodes posteriorly esophagus and vertebral column. On the right side, 1 right lung and pleura. 2 right vagus. 3 azygous vein. On the left side, 1 arch of aorta, left common carotid and left subclavian arteries. 2 left recurrent laryngeal nerve. Structure: the trachea has a fibroelastic wall supported by a cartilaginous skeleton formed by C-shaped rings. The rings are about 16 to 20 in number and make the tube convex anterolaterally. Posteriorly there is a gap which is closed by a fibroelastic membrane and contains transversely arranged smooth muscle known as the 3 trachealis. The lumen is lined by ciliated columnar epithelium and contains many mucous and serous glands. 4 arterial supply, 5 inferior thyroid arteries. 6 venous drainage. 7 into the left brachiocephalic vein. Lymphatic drainage to the pretracheal and paratracheal nodes. Nerve supply. 1 parasympathetic, nerves through vagi and recurrent laryngeal nerves. It is A sensory and secretomotor to the mucous membrane. B motor to the trachealis muscles. 2 sympathetic, fibers from the middle cervical ganglion reach it along the inferior thyroid arteries and are vasomotor. In radiographs, the trachea is seen as a vertical translucent shadow due to the contained air in front of the cervicothoracic spine, Fig 21.12. Clinically the trachea is palpated in the suprasternal notch. Normally it is anedian in position. Shift of the trachea to any side indicates a mediastinal shift. During swallowing when the larynx is elevated, the trachea elongates by stretching because the tracheal bifurcation is not permitted to move by the aortic arch. Any downward pull due to sudden and forced inspiration, or aortic aneurysm will produce the physical sign known as tracheal tug. Tracheostomy: it is a surgical procedure which allows air to enter directly into trachea. It is done in cases of blockage of air pathway in nose or larynx. As the tracheal rings are incomplete posteriorly, the esophagus can dilate during swallowing. This also allows the diameter of the trachea to be controlled by the trachealis muscle. This muscle narrows the caliber of the tube, compressing the contained air if the vocal cords are closed. This increases the explosive force of the blast of compressed air, as occurs in coughing and sneezing. Mucus secretions help in trapping inhaled foreign particles, and the soiled mucus is then expelled by coughing. The cilia of the mucous membrane beat upwards, pushing the mucus towards the pharynx. The trachea may get compressed by pathological enlargements of the thyroid, the thymus, lymph nodes, and the aortic arch. This causes dyspnoea, irritative cough, and often a husky voice. Dissection. Remove the posterior surface of the parietal pericardium between the right and left pulmonary veins. This uncovers the anterior surface of the esophagus in the posterior mediastinum. Find the esophagus vein and its tributaries on the vertebral column to the right of the esophagus. Find and follow the thoracic duct on the left of esophagus vein. Identify the sternal, sternocostal, interchondral, and costochondral joints on the anterior aspect of chest wall which was reflected downwards. Expose the ligaments which unite the heads of the ribs to the vertebral bodies and intervertebral discs. Features. The esophagus is a narrow muscular tube, forming the food passage between the pharynx and stomach. It extends from the lower part of the neck to the upper part or the abdomen, Fig 20.4. The esophagus is about 25 centimeters long. The tube is flattened anteroposteriorly and the lumen is kept collapsed. It dilates only during the passage of the food bolus. The pharyngoesophageal junction is the narrowest part of the alimentary canal except for the vermiform appendix. The esophagus begins in the neck at the lower border of the cricoid cartilage where it is continuous with the lower end of the pharynx. It descends in front of the vertebral column through the superior and posterior parts of the mediastinum, and pierces the diaphragm at the level of 10th thoracic vertebra. It ends by opening into the stomach at its cardiac end at the level of 11th thoracic vertebra. Curvatures. In general, the esophagus is vertical, but shows slight curvatures in the following directions. There are two side-to-side curvatures, both towards the left, see Fig 17.4. One is at the root of the neck and the other near the lower end. It also has anteroposterior curvatures that correspond to the curvatures of the cervicothoracic spine. Constrictions. Normally the esophagus shows 4 constrictions at the following levels. 1 at its beginning, 15 cm/6 inch from the incisor teeth, where it is crossed by cricopharyngeus muscle. 2 where it is crossed by the aortic arch, 22.5 cm/9 inch from the incisor teeth. 3 where it is crossed by the left bronchus, 27.5 cm/11 inch from the incisor teeth. 4 where it pierces the diaphragm, 37.5 cm/15 inch from the incisor teeth. The distance from the incisor teeth are important in passing instruments like endoscope into the esophagus. For sake of convenience, the relations of the esophagus may be studied in 3 parts: cervical, thoracic, and abdominal. The relations of the cervical part are described in Volume 3, and those of the abdominal part in Volume 2 of this book. Relations of the thoracic port of the esophagus anteriorly: 1 trachea, 2 right pulmonary artery, 3 left bronchus, 4 pericardium with left atrium, 5 the diaphragm. Posteriorly: 1 vertebral column, 2 right posterior intercostals arteries, 3 thoracic duct, 4 esophagus vein with the terminal parts of the hemiesophagus veins, 5 thoracic aorta, 6 right pleural recess, 6 diaphragm. To the right, 1 right lung and pleura, 2 esophagus vein. The right vagus, Figs 20.5a to c, to the left 1 aortic arch, 2 left subclavian artery, 3 thoracic duct, 4 left lung and pleura, 4 left recurrent laryngeal nerve, all in the superior mediastinum, see Figs 19.3 and 19.9. In the posterior mediastinum, it is related to 1 the descending thoracic aorta, 2 the left lung and mediastinal pleura. Arterial supply: 1 the cervical part including the segment up to the arch of aorta is supplied by the inferior thyroid arteries. 2. The thoracic part is supplied by the esophageal branches of the aorta. 3. The abdominal part is supplied by the esophageal branches of the left gastric artery. Venous drainage. Blood from the upper part of the esophagus drains into the brachiocephalic veins, from the middle part it goes to the esophagus veins, and from the lower end it goes to the left gastric vein and vena esophagus via hemiazygos vein. The lower end of the esophagus is one of the sites of portosystemic anastomosis. Lymphatic drainage. The cervical part drains to the deep cervical nodes, the thoracic part to the posterior mediastinal nodes, and the abdominal part to the left gastric nodes. // supply. Parasympathetic. The upper half of the esophagus is supplied by the recurrent laryngeal nerves, and the lower half by the esophageal plexus formed mainly by the two vagi. Parasympathetic nerves are sensory, motor and secretomotor to the esophagus. 2 sympathetic nerves. For upper half of esophagus, the fibers come from middle cervical ganglion and run with inferior thyroid arteries. For lower half, the fibers come directly from upper 4 thoracic ganglia, to form esophageal plexus before supplying the esophagus. Sympathetic nerves are vasomotor. The esophageal plexus is formed mainly by the parasympathetic through vagi, but sympathetic fibers are also present. Towards the lower end of the esophagus, the vagal fibers form the anterior and posterior gastric nerves which enter the abdomen through the esophageal opening of the diaphragm. In portal hypertension, the communications between the portal and systemic veins draining the lower end of the esophagus dilate. These dilatations are called esophageal varices. Rupture of these varices can cause serious hematmesis or vomiting of blood. The esophageal varices can be visualized radiographically by barium swallow. They produce worm-like shadows, Fig 20.6. Left atrial enlargement as in mitral stenosis can also be visualized by barium swallow. The enlarged atrium causes a shallow depression on the front of the esophagus. Barium swallow also helps in the diagnosis of esophageal strictures, carcinoma, and achalasia. The normal indentations on the esophagus should be kept in mind during esophagoscopy, Fig 20.7. The lower end of the esophagus is normally kept closed. It is opened by the stimulus or a food bolus. In case of neuromuscular incoordination, the lower end of the esophagus fails to dilate with the arrival of food which, therefore, accumulates in the esophagus. This condition of neuromuscular incoordination characterized by inability of the esophagus to dilate is known as achalasia, Fig 20.8. It may be due to congenital absence of nerve cells in wall of esophagus. Improper separation of the trachea from the esophagus during development gives rise to trachea-esophageal fistula, Fig 20.9. Compression of the esophagus in cases of mediastinal syndrome causes dysphagia or difficulty in swallowing. 4. Thoracic duct. 5 features. 6. The thoracic duct is the largest lymphatic vessel in the body. It extends from the upper part of the abdomen to the lower part of the neck, crossing the posterior and superior parts of the mediastinum. It is about 45 cm/18 inch long. It has a beaded appearance because of the presence of many valves in its lumen, Fig 20.10. 7. Course 8. The thoracic duct begins as a continuation of the upper end of the cisterna chyli near the lower border of the 12th thoracic vertebra and enters the thorax through the aortic opening of the diaphragm. It then ascends through the posterior mediastinum from level of 12th thoracic vertebra to 5th thoracic vertebra where it crosses from the right side to the left side. Then it courses through the superior mediastinum along the left edge of the esophagus and reaches the neck. In the neck, it arches laterally at the level of the transverse process of 7th cervical vertebra. Finally it descends in front of the first part of the left subclavian artery and ends by opening into the angle of junction between the left subclavian and left internal jugular veins. Relations. At the aortic opening of the diaphragm. Inferiorly, diaphragm. Posteriorly, vertebral column. To the right, azygous vein. To the left, aorta. In the posterior mediastinum anteriorly, L diaphragm. 2. Esophagus. 3. Right pleural recess. Posteriorly. 1 vertebral column. 2 right posterior intercostal arteries. 3 terminal parts of the hemiazygos veins. To the right, azygos vein. To the left, descending thoracic aorta. In the superior mediastinum anteriorly. 1 arch of aorta. 2 the origin of the left subclavian artery. Posterior vertebral column. To the right, Oesophagus.to the left pleura. In the neck. The thoracic duct forms arch rising about 4 cm above the clavicle. The arch has the following relations. Anteriorly, 1 left common carpted artery. 3 left vagus. 4 left internal jugular veins. Posteriorly, 1 vertebral artery and vein. 2 sympathetic trunk. 3 thyrocervical trunk and its branches. 4 left phrenic nerve. 5 medial border of the scalenus anterior. 6 prevertebral fascia covering all the strictures mentioned. 7 the third part of the left subclavian artery. Tributaries. The thoracic duct receives lymph from, roughly, both halves of the body below the diaphragm and the left half above the diaphragm, Fig 20.11. In the thorax, the thoracic duct receives lymph vessels from the posterior mediastinal nodes and from small intercostal nodes. At the root of the neck, efferent vessels of the nodes in the neck form the left jugular front, and those from nodes in the axilla form the left subclavian front. These trunks end in the thoracic duct. The full bronchomediastinal trunk drains lymph from the left half of the thorax and ends in the thoracic duct. Trachea contains C-shaped hyaline cartilaginous rings which are deficient posteriorly, so that the esophagus situated behind the trachea is not compressed by trachea. Trachea begins at 6th cervical vertebra and ends at thoracic 4, in expiration, by dividing into 2 principal bronchi. Trachea is always patent. Esophagus is 25 cm long, like duodenum and ureter. Its maximum part about 20 cm lie in thoracic cavity. There is no digestive activity in the esophagus. Lower part of esophagus is a site of portocaval anastomosis. Thoracic duct drains lymph from both lower limbs, abdominal cavity, left side of thorax, left upper limb and left side of head and neck.